So we've been working on this for some time, as Raji pointed out, for the last 3-4 years, and Kinori had shown what is the machine learning and deep learning. So today there are multiple places, as Raji pointed out, where AI has been approved by FDA. But the current, the algorithm that we have been working on is yet to be approved. They say that the C certification is almost there, but so to use it independently is not possible at this point of time. But how AI makes a big difference in ours is because of the images. Most of our diagnosis is based on images, and so it becomes more applicable in the ophthalmologist, just like the radiologist or the dermatologist using this. And we have a clear-cut guidelines, the grading system and the grades that have been well established. So we have been using this as a grading, the opportunistic screening. We put cameras in the physician's office for the last 15, almost 17 years, trying to take their, whenever a patient walks in, because that is where you get the target population and not the patients who are walking into your clinic for ophthalmology. So we call it as opportunistic screening because every diabetic patient would get a fundus photo taken and their image is read through telescreening by an ophthalmologist or a trained grader, and a report is sent back. So the whole idea is that the whole grading is so inconsistent, as Akinori pointed out. When 2 or 3 different people are grading the same, a PDR could be read as mild or moderate, as you can see in this, where even a proliferative diabetic retinopathy was considered as a mild NPDR. So this, our study done earlier had shown a very good high sensitivity of 97% and 96% sensitivity and specificity in our earlier studies, and I think most of this have been read. So today what we are trying to do is we are trying to introduce the ARDA. So every patient the physician takes or the diabetologist take is subjected to ARDA, is the Google's algorithm. At the same time, the image is also read by an ophthalmologist or the trained grader in the base hospital. And once he finishes grading, the ARDA's report comes into his reading. So if there is any difference, then it is sent for adjudication to a senior level or a senior retina specialist to see which is the ground truth. And that is generated as a report and sent back to the to the diabetology clinic. So this, we call it as assisted grading and not an independent grading by ARDA at this point of time, for a simple reason: it's not certified by anybody at this point of time. So we are trying to do, as Kinori and Rajiv also pointed out, performing these real-time scenarios. How does it work when we are using on the real scenarios? And we have seen that the sensitivity of 88.9% and the specificity of 92% was there for moderate plus DR grading. So those patients who had moderate or more than moderate diabetic retinopathy, the sensitivity was quite high. Both in Arvind and in Shankar Nethralaya, it was 92% and the specificity of 95%. It did work well even for when we looked at the diabetic macular edema, a sensitivity of 97.4% and specificity of 90% in the Arvind's group of images, and in Shankar Nethralaya it was about 93 and 92.5% sensitivity. So it did show that it was doing very well in comparison to the ground truth. And so the whole idea is that over time we will remove the entire grading of human grading being there, and the images that come from the physician's office or diabetologist's office will locally be uploaded to the ARDA, and they get a report within a few seconds, and there's no time delay for the patient, and with much more sensitivity and consistent way of grading. So that's what we're looking at. We're also deploying, we have been using these cameras in our what we call as primary care centers or vision centers, where only a technician is present doing the complete examination of the patient, where the diabetic patient's fundus photos are taken and sent for grading. We are currently using the ARDA as an assisted grade, but soon we hope, like with all the algorithms available, people are working on glaucoma, people are working on AMD, and all the other common retinal pathologies that will be available, and if they could be put in place, then we could have a system wherein the primary technician or a primary care provider could screen the patients and triage the patients. Only those who have any serious form of retinal pathology or any disease like glaucoma could be referred to the ophthalmologist, so that it gives more. The ophthalmologist did not screen through these normal patients. So we have had a few challenges in technical using, the technicians using these cameras. Still the acceptance from the physician is questionable. We have to wait for them to see how it matches, and we have to convince them on the grading system, how it works better than the human grading, and sometimes getting consent from the patient, because in all these we have to get consent from the patients that we are doing this as an assisted grading, but sometimes it becomes a challenge. The other thing is the types of cameras used. Still we need to have a very good high resolution cameras, and currently they are available. The algorithms need to be trained on all cameras, as I was mentioning earlier. And of course the technician needs adequate skill to get good quality images, but today there are few cameras which are automated. Of course they are still expensive. There is no role for the technician other than just entering the data that anybody can do, and the camera itself automatically focuses on the different areas for the patient to see, and then we get a very good resolution, high resolution images even with 2.5 millimeter pupil. So what's next? To determine whether the use of these algorithms could lead to improved care and outcome compared with the current ophthalmic assessment is something that we have to study with time, and this is what we are currently looking at, how these images, if we did independently, how would it function versus a physician or a trained grader grading these images. As somebody said, Andrew said, that AI is the new electricity. It's going to change a lot of things. As we all hear about AI in every field, not only in healthcare, but automotive industry or any industry, even in judiciary using AI. So it's not something going to be, we cannot stop it, but it'll be there. How we adapt it is more important, and how we use it is very, very important in this. So I thank you for your kind attention.